So, for the last talk of the morning, it's my pleasure to welcome back Sara Crager. And you're going to carry on the discussion and the learning from yesterday with a tale of three pressures.
Hey, everybody. Can you hear me? Microphone, good, working, beautiful. So I promised me and the last speaker we're not in cahoots because I'm going to pick up exactly where he left off. And we didn't plan this, I promise. So we're going to talk again about rethinking shock. And I am again trying to convince you that we really need to change the way that we approach it. Not just because it's academic and I need something to talk about at this conference, but because it actually makes a difference for patients. Now, at some point we will have some slides up, but we're just going to get started anyways. So when we think about shock, as we were just talking about, we think about MAP, and we all talk about that forward pressure because humans are very forward-centric creatures. We like forward things. But as we just talked about, the back things are also very important. So we'll just skip the slides for today. We don't really need them. We'll get them eventually. When I approach a patient, I often get the following consult. I have somebody call me. Sometimes it's a resident. Sometimes it's somebody in the ED. And they say something like this. I have this patient. And they came in and they were kind of shocky. They were hypotensive. So I gave them a couple liters of fluid. And actually their blood pressure got worse. And actually their lactate got worse. So then I started them on some norepi, but now the norepi dose is escalating and their lactate's still getting worse. Please advise. What do you think? We've all been in that situation. We've all had that moment when we're like, what now? You know that book of poems, the Shel Silverstein one, the Where the Sidewalk Ends one? Yeah, we have that moment where you're like, I've done all the things. What other things are there that you want me to do? That moment. And me having that moment with so many patients was what convinced me that I need to learn to think about shock differently. Because if it was just one patient every now and then, I'd be like, okay, that's just a one-off. But it's a lot of the time. And I think the way that we were all taught to think about shock is insufficient. It's like that Einstein quote. Everything should be as simple as possible, but no simpler. And I think that we've oversimplified shock. And now I even have a presenter. Lovely. So here we go. This is the patient that I'm talking about right here, this critical care consult. Hypotensive after you've done all the things. And we have this moment. This I've done all the things, what next? And when we have this moment, what do we do? What should we do when there's a complex clinical problem that we don't know how to solve? And I think that our first instinct is fancier technology. Maybe we just need a new advice that we can use. Sometimes more research. You know how every research article at the end is like, more research needs to be done. Maybe if we do that more research, we'll have the answer and really maybe actually take that research, put it together into a new guideline or algorithm. Now, why is it that we like more research, more technology, more algorithms? I think it has something to do with this. Another one of my favorite quotes in medicine. This illusory sense of the psychological security that we get from these precise tools. We have a paper that tells us what to do. We have a technology that gives us a number, or we literally have arrows that we can follow. We like that. What we don't like as much is the idea that what we actually need to do is think better. And I think we need to go beyond the traditional way that we were taught shock. How were we all taught shock? How did I used to teach shock? Categories. There's 4 categories of shock. You're hypovolemic, distributive, cardiogenic, and obstructive. And what that ends up having you do is be like, which shock box do I put my patient in, right? And that's what you're trying to figure out. Now, part of the problem with this model is that it doesn't give us a great way at the bedside to try and figure this out. So some bright person came up with this, our pipes, pump, tank. And what this really does for us is providing an ultrasound framework, an investigatory framework at the bedside for how we try and determine which category of shock our patient fits into. But we cannot forget that ultrasound is simply a tool for gathering data. And if all you can do with that data is put it in the same old boxes again, you haven't really gotten yourself very far. Now, one of the problems with this is increasingly we're beginning to understand that you cannot conflate the shock precipitant with the shock physiology. We used to think that septic shock was kind of synonymous with distributive shock, that in cardiogenic shock, they're supposed to be wet and cold, and their extremities are cold and they're clamped down. Turns out, not so much. Turns out there's maybe a little more overlap than we thought. So this was a paper, one of my favorite papers recently, looking at right ventricular failure in patients with septic shock. And all these patients definitely had septic shock. Turned out about a third of them also had right ventricular failure. Who cares? Well, it also turned out it was clinically significant. Why? Because there was higher mortality in those patients. So is septic shock distributive shock? Is there also something about the heart in septic shock? What about this one? This study looked at a bunch of patients admitted to the CCU. The cardiologist had to admit them, and as we all know, it's hard to talk a cardiologist into admitting to the CCU. They're like, no, it's kind of a MICU thing, maybe it's a CTICU thing. All these patients, they had to be convinced enough that it was a primary cardiac thing, primary cardiogenic shock, to go to the CCU. What did they find? About a third of those patients were positive for SIRS criteria. And again, significantly, it had a mortality implication. The patients in purportedly cardiogenic shock who are supposed to be vasoconstricted, in fact, not so much. In fact, a lot of them were positive for SIRS, and it had medical, clinically relevant implications. So that's one of the reasons that these 4 traditional categories of shock I just don't think are enough. But most importantly, they have management implications. Why? Because these 4 categories of shock dictate very specific management strategies. If we're in hypovolemic shock, we give volume. Distributive shock, we give pressors. Cardiogenic shock, we give inotropes. And obstructive shock, we decompress it. Similarly, our pipes pump tank does the same thing. We give pressors if we think it's a pipes problem. We give volume and inotropes if we think it's a pump or a tank problem. But this, right here, these different categories dictating specific management strategies is a problem. Why? Because this is where we end up here. We end up where the sidewalk ends. Why? Because once we've done those things, what now? What do we do next? And this is where I came to, we need to do next, reframe our mental model of shock physiology. And as we just talked about, it's not about the map, it's about perfusion pressure. Now, the idea that we should think about shock as perfusion pressure, don't blow your mind. This is not a novel concept. I didn't come up with this just for this talk. This is how, if you've done a critical care fellowship, you're taught this. It's all about perfusion pressure. It's about the interactions between different pressures. The problem is that this idea hasn't quite caught on for a reason, and this is the reason. This is how I was taught this, and that's just not super functional at the bedside, it turns out. So what I'm going to try and do here is not so much come up with a novel model for shock, that it's about perfusion pressure, yes, we know that. Rather, we'd like to go through a process of what I call advanced simplification, where we take this knowledge that we have and actually make it functional for daily use. The way that we are going to do that for shock is step number 1. As we talked about yesterday, we really have to embrace the fact shock is not about hypotension, it's about hypoperfusion. And it's tissue perfusion that we care about, that is where the magic happens. Now, as we also talked about, we're really into blood pressure. Despite knowing that it's tissue perfusion that matters, what do we actually talk about? What do we care about on a daily basis? Blood pressure. Now, partially that's because we can measure it, we like to measure it, but I think that our blood pressure obsession runs deeper than that. And it runs into the fact that humans, by nature, are very forward-centric creatures. If you don't know this, think about what you just got told on the plane. You got told the nearest exit may be behind you. Now, this seems obvious, right? Why do they feel the need to announce this? Because humans are naturally very forward-centric. And what that means in terms of our hemodynamic worldview is our forward-centricness makes us very map-centric and very LVEF-centric. But does this really matter when we're thinking about this? Because, the forward pressure is not what really matters. The problem is that if all you're thinking about is the forward pressure, yes, that's a component of the system, but if that's all you focus on, you're missing the rest of what turns out to be a very complex system. It's like this. Let's say you have a big boulder, and I'm trying to push the boulder forward. And I'm pushing, and I'm like, it's not going anywhere. Why isn't it moving anywhere? Maybe I just need to push harder. Until I realize there's actually another dude on the other side who's pushing back against me. And rather than pushing forward harder, I could be like, buddy, can you just stop doing that, please? And this, functionally, is where we got to in the last talk. It's about perfusion pressure. It's about the forward pressure minus the back pressure, or physiologically, the MAP minus the CVP. But why don't we care about that? I think partially it's because we're like, well, but the forward pressure, relatively speaking, is so much higher than the back pressure. The back pressure is negligible relative to that forward pressure, so I don't care. But you should care. Why? To understand why you care about this, we need to go back to a diagram that I learned in med school, promptly forgot because I was like, this isn't useful. Turned out it was. This is a diagram that looks at the various levels of the circulatory system, starting at the aorta, going all the way down through the capillaries to the vena cava. And what it does is it looks at the pressure at various points in the circulatory system, and it maps us out for this. Now, recall that what we actually care about is right here in the capillaries. That is where the magic happens. That is where the tissue perfusion happens. Now, the key thing to understand about this diagram, why it is important, is because look where the biggest drop in pressure happens. Right before the magic happens, right before the tissue perfusion happens. So we're used to thinking about our forward pressures as somewhere up here, those nice pressures we have in the aorta. But wait a minute, that is not actually the forward pressure deriving our pressure gradient through the capillaries. That actually is more down here. And now when you're looking at, oh, wait a minute, that is the forward pressure immediately before the magic happens, all of a sudden, it's not that negligible compared to the back pressure. And so really, rather than looking like this, it probably kind of looks more like this. And so instead of all being super, super focused on forward pressure, maybe we get excited a little bit about back pressure. So this allows us to ask some interesting clinical questions like, is it that we have insufficient forward pressure, or maybe we have excessive back pressure? Now, there's another pressure we need to talk about here that turns out to also be important, and that is our external pressure, our third pressure. So let's say that we have our rock. I'm trying to push it forward, this other guy's trying to push it back. I'm having a really hard time pushing it forward. I talked to this other guy to be like, can you just back off a little bit? But I still can't push it forward. Well, turns out there's a third guy who's sitting on top of my rock, and he's a big fat guy, and now I'm like, okay, well, of course I can't push it forward, so maybe instead of pushing harder, I need to be like, can you just get off my rock, everybody? This is our forward, backward, and external pressures. Now, functionally, what do we mean by external pressures? Well, often they're really, really obvious. We all know this. Why? Because often when our external pressure shows up, it is lit up, it is obvious, we can't miss it, it's this. Tension pneumothorax and cardiac tamponade. We're all highly familiar with these things. Why? Because you can't miss them. Now, think about it. If your patient has tension pneumothorax or cardiac tamponade, what do? You're not like, oh, I better push forward harder. You're not like, oh, I better give pressors or volume. You're like, oh, I got to get rid of that external pressure. Now, this is when it's obvious, but less obvious, tiny but mighty. There's something else. There's another external pressure that we don't think a lot about, but matters, and that is tissue hydrostatic pressure. And if we're thinking about the fact that the level of the capillaries, where that magic happens, our forward pressure is more like, what, 20? Our back pressures may be 8, and that is the magnitude of pressures we're talking about. Now, all of a sudden, tissue hydrostatic pressure, relative in magnitude to those other two pressures, actually kind of matters. So, these are our three pressures. This is the advanced simplification framework that I like to use to think about shock. But how do we bring this to the bedside? Because understanding these three competing pressures, these are the building blocks. In order to take this to the bedside and to functionally use it to know what's going on with my patient, what we need to do is a little more complicated. What we need to do is we need to create a map, whether it's a mental map or sometimes I'll even just write this down and create a physical map of the circulatory system. And on that map, we then map the physiology of our forward, backward, and external pressures. Now, if you're taking a picture of this, there's also a diagram of this on the website that I have, and so you can just look at it there. But my goal in this talk is not to talk through everything on this diagram, because what you actually need to do, taking hours by yourself at home, is to go through the physiology of each of these pieces. If you go and look at my website, there's actually a lecture that goes through the detailed physiology here. But the thing that I want you to take home from this lecture is the following. What this really is an organizational system. what this provides you with is a closet, so to speak, a framework for organizing the different pieces of data you obtain from your patient. And rather than trying to take that data and say, okay, I'm going to stuff all of this data into a single box, the idea is to use this framework to organize your data, to understand what are the different factors contributing to hypoperfusion in my patient. And then what you can do is you can sit down and say for Mr. Doe right here, we can map out all the data on this framework to be like, okay, what does this look like for my patient? And most importantly, what can we do next? We can now use this to inform us about various different management strategies, some of which are not obvious. Now, it's kind of like anything else. Once you get used to doing this, often you can kind of do it in your head. But if I have a complicated patient, like actually the shift before I left for this conference, if you have a complicated patient, I'll just write it down. This is the most recent one of these that I wrote down at the bedside. I had this super sick patient in the SICU, and my handwriting is kind of messy, apologies, but I had this super sick patient, and I was like, I'm doing everything, I'm doing all the things, why are they not getting better? And I can sit down, map it out, and this is an evolving map. Because our patients are allowed to have more than one thing wrong with them. They're allowed to develop more than one thing wrong with them. And once I've drawn this map, I can now let it evolve. I can let it suggest new things I need to do, and I use it as a checklist for things maybe I need to rule out. Now, is this easy? No. This takes an investment of time and thought. But unlike this, I find that it's actually functional at the bedside. And if we think about all the time we invest in medicine, I mean, how much time do we spend reading new journal articles, going to journal club? How much time do we spend updating ourselves on the most recent guidelines, or maybe looking into the most recent technologies? If we think about that time investment versus how little time we invest in learning how to think better, I would argue maybe our patients deserve for us to spend just as much time learning to think better. Sitting down, developing these mental models, going through a framework, practicing thinking better, and using that strategy at the bedside. Because as opposed to our 4 categories of shock, as opposed to our pipes, pump, tank model, what I find is that this model, what it does for me, if I sit down, write it out with the patient in front of me, what it will do for me is allow me to figure out an approach to this patient right there and patients like them. And what it allows me to do is to avoid more moments like this. Thank you, guys.
Amazing. And any questions from the audience?
Thanks, that was great. And it's always nice to see some of your own biases reinforced by other people. The most common drug I prescribe is furosemide. And I was really excited to see there on your diagram, furosemide and pressors and inotropes at the same time. How do you get around the inevitable people who will question this and say, hang on, you're crazy, what are you doing? They're interested to hear about the challenges involved in transitioning to this model from people who are very dogmatically fixed on the other models.
Yeah, it's actually really hard. People, as you've suggested, if you have a patient who's hypotensive and you propose giving them furosemide, everybody loses their mind. The nurses come up to you and they're like, did you notice the patient was hypotensive? And you're like, yes, that's why I'm giving it. Or they're like, did you see the creatinine's high? And you're like, yes, that's why I'm giving it. This is actually where the rock analogy came up, is I had this argument so many times that I was like, I need to find a way to explain this. And that's where I came up with the rock analogy. And I first started explaining it by trying to explain the physics, that pressure and flow are 2 different things, and everybody gave me blank looks, and I was like, that's not gonna work. So I found a simple way to explain it to people, that it's about actually how much forward flow you have. And if we need to tell the guy sitting on the rock or the guy pushing the other way on the rock to move on, you gotta find a simple analogy. And I also, if you're working with the same team, explain it over and over again. And what I find is there's 2 kinds of people. There's one kind of person who really actually wants an explanation, like they want to understand it. And for those people, I actually start drawing these diagrams, and when they see that it works, that's when they're really convinced. You gotta show them it works a couple times. But then there's the kind of people who just are like, nope, it's hypotension, we can't give furosemide. And you explain it and they're like, nope, it's hypotension, you can't give furosemide. And you're like, okay. For those people, I still explain it in a great amount of detail and I try and talk really fast. And I usually do that until they're like, okay, I believe you. What they mean is stop talking to me, please. And hopefully, by that, I can convince them that, yes, I know what I'm talking about. And then if I can show them it works, they don't know why it works, they have no idea what I'm talking about, but it's okay. So it takes an investment in your team, but you can get there eventually, but it's really hard when you have a new team. So it's difficult, but I think a simple analogy, them seeing that it works and sort of spreading it throughout the team. And I know it was working when I saw one of my residents drawing out this diagram for one of the nurses, and I was like, we are there, we got this. Other questions?
Say I do use the talking fast at people, hoping that they will let me get away with it. But then my wife tells me to shut up. So
Yeah, that's fair enough. Do not try this.
it doesn't seem to work. Any other questions? Well, thank you so very much. 2 amazing talks. And I think one of the hallmarks of a great educator is taking something really complicated like that and making it simple. And thank you so very, very much.
Thank you.